Today, my name is Muhammad Azim. So today our group will discuss on the approach to hernia and history taking. Next. Okay, this is the presentation outline. Okay, next slide. Okay, first, a hernia is basically the protrusion of an organ through its containing wall. So at the side, we can see the picture of an anatomy of an hernia. Okay, next. Okay, so anatomy of hernia consists of sacs, covering of the sacs, and content of the sacs. Okay, next slide. Okay, first, the sac is consists of a diverticulum of peritoneum, consists of mouth, neck, and body, like the picture that we seen before. And second is covering of the sac, which is a layer of abdominal wall through which the sac pass. And third is contents of the sacs. It depends on the part that is herniated. It can be omentum, intestine, and etc. Okay. Okay. Next person.
Yeah, Assalamualaikum and good morning. Today I'm going to present about the risk factors and the causes of hernia. So first we start
Berapa
with the
orang
risk
presenter ni?
6.
Ha?
6 presenter.
Tak ada, saya nak 3 orang je presenter maksimum. Kenapa sampai 6 orang ni? Apa pasal ramai sangat presenter sampai 6 orang?
Sebab all group member present.
Apa dia?
That's sebab semua group member present.
You all ada banyak topik lagi nak present. Nah, ya topik tu bukan seorang sekali present. Seorang, kalau you buat macam ni, seorang 5-6 kali kena present. Berapa slide semua ada? You all dengar tak?
Ada 30 slide.
Macam mana you nak present sampai 6 orang 30 slide? Topik pendek je. Continue.
Okay, so first the risk factor of hernia is age. As years progress, the tissue
Presenter, please on your video. Kalau yang lain tak nak on semua sekali pun, at least presenter on the video.
Macam doktor nak pakai tudung. Okay, so first the risk factor is age. This is because as years progress, the tissue and the muscles, they get weaker, and this will increase the risk of getting hernia. Second is smoking. Smoking is because it is associated to my third point, which is chronic cough. When a person coughing has been shown to raise the abdominal
Your slide
pressure.
smoke, bukan smoking.
Sorry, I will refix it later. It's smoking actually. So it is related to my third point of chronic cough, of where cough has been shown to raise the intra-abdominal pressure. And so it means that patients who cough due to smoking, bronchitis, asthma, COPD, they have a higher risk of developing hernia. The next one is chronic constipation. Constipation is associated with straining. So when a person strains, it increases the intra-abdominal pressure, which could increase the risk of hernia formation. So the principle here is that anything that increases the intra-abdominal pressure will increase the risk of getting hernia. Pregnancy itself, it increases the intra-abdominal pressure. Next is heavy lifting. Heavy lifting is because lifting heavy weights on a daily basis, it has the potential of increasing the risk of developing hernia. Here, I did not state weightlifting. This is because in Bailey and Love, it is stated that not all Olympics weightlifter they develop hernia. So it means that people who overstrain with or inappropriate weightlifting that could cause increase the risk of developing hernia. And the last one is previous surgical scar. This is because in Bailey and Love 2, it is stated that a person who has surgical scar, even though the with perfect wound healing, it has 70% it only has 70% of the initial muscle strength. So this can increase the risk of getting hernia. That's all for the risk factor. Next. Okay, these are the causes of hernia. For the causes of hernia, the first one is because of basic design weakness. Despite the complex design of the abdominal wall, the only natural weakness that is caused by inadequate muscle strength are the lumbar triangles and the posterior wall of the inguinal canal. The lumbar triangle, it is not as thick as the rest of the abdominal wall. So this is a site of a potential weakness that can lead to a hernia. The posterior wall of inguinal canal, if you guys remember last time that we learned, it has an opening which is the deep inguinal ring. That deep inguinal ring, it is the weaker part of the posterior wall of inguinal canal. The second one is weakness due to structure entering and leaving the abdomen. This is because there are many structures that pass into and out of the abdominal cavity. A common example is the inguinal canal in male, and in female it is the round ligament. The round ligament. So this structure that enter and leave the abdomen, this can result in weakness to the muscle and cause hernia. The next one is developmental failures. So for the developmental failure, this example is the failure of the processus vaginalis to close. As the testis descends, it actually pulls a tube of peritoneum with it. So when this tube of peritoneum, it should actually fibrose and obliterate. But what happens here when it fails to fibrose, it causes hernia to develop. The next one is genetic.
That is not developmental failure.
Is it congenital?
What do you mean by congenital failure? When you say congenital failure, what do you understand?
The organ that couldn't develop fully during birth.
Yes.
So is it
This is not an organ who doesn't develop. This is failure of closure. It's not developmental failure.
Okay, so this is under failure of closure. So I'm sorry, I will fix it later.
I didn't say it's not. I didn't say the name is under failure of closure. It's the processus vaginalis fails to close, but it's not considered as developmental failure.
So is it only an anatomical?
Continue.
Okay, next one is genetic weakness of collagen. There is a good evidence that hernia is a collagen disease, and it is because of an inherited imbalance in the types of collagen. The next one is weakness due to pregnancy, like how I've explained in the risk factor just now, it is increase in intra-abdominal pressure. And also during pregnancy, there is a change in the hormones. So this will increase the laxity of the pelvic ligaments, which can lead to hernia. And the last one is weakness due to aging. And hernia is common in elderly due to degenerative weakness of muscle and fibrous tissue. That's all. Okay.
Okay. Assalamualaikum semua. Can you hear me? Can you hear me?
Yes.
Yes.
So now everyone has encountered the definition, the risk factors, and the causes of the hernia. So now I will proceed with the types of hernia. Okay. So next slide. Okay. So for the types of hernia, there are actually many types of hernia. Okay. But from the brow surgery books, there are only 5 common types of hernia. So if you can see at the picture I put there, okay, so that is the examples of the hernia and the sites it develops. And in the table, I put the examples of the hernias, okay, following orders of common. The most common hernia is the inguinal hernia. Okay, so maybe I'm just going to read briefly the just introduction to the each type of the hernia, but later we will go through a bit detail about each types of the hernia. So to know, to memorize the name of the hernia is not really difficult. It's quite easy because the name of the hernia is actually corresponding to the site it develops. So for example, the first one is the inguinal hernia, which is the most common type of hernia. Okay, from Brown's book, it said that it is a protrusion of part of the content of the abdomen through the inguinal region of the abdominal wall. Okay, it appears through the external inguinal ring, or also known as the superficial inguinal ring, above and medial to pubic tubercle. So I hope everyone can still remember where the pubic tubercle is, and it can be direct or indirect inguinal hernia. Okay, the details of it I will explain later in the next slide. Okay, and next is the umbilical hernia. Okay, umbilical hernia is, as you can see in the picture, it is at the umbilical region. Okay,
What is the percentage?
Percentage of you mean the comparison ke? I mean between female and male?
Percentage of all the hernia. Then how do you know which is the most common, which one is less common?
For inguinal hernia, it is more common in male compared to
I'm
women.
not asking it's more common in male or female. I asking you the percentage, the incidence.
I'm sorry, doctor, that one, wait.
Doctor, from Bailey and Love, it mentions that for inguinal hernia, it is 80%.
Siapa ni? You all dah lah, you all lecturer tak kenal you all cakap tak tahu siapa.
Sorry, Doctor, I'm Alia. I'm the one who's speaking right now.
Mana presenter tadi?
Sekejap doktor, saya
Berapa persen?
Doctor, sorry, I cannot find. I'm searching in Bailey and Love, but Alia, can you?
This is not time for you to save dah. You presenting dah. You nak save tunggu berapa lama? You all masa limited. Saya pun tak nak buka lama-lama. Bukan you all fokus pun nanti.
Sorry, doctor.
Then how you know that is yang cakap common ke tak?
I read it from the Bailey and Love and Browse book. It just said that it is common in male compared to female, but it
I'm
doesn't
not
state
asking whether it's common in male or female. I'm asking you what is the percentage, the incidence.
That one I don't.
How going to support your statement just now? How do you know why femoral hernia, umbilical hernia is more common than femoral hernia? What is the percentage?
Sorry, doctor, about the percentage. I cannot find now. Maybe any other of you knows?
Mana Alia tadi?
Ya, saya kat sini, Doctor.
You say something?
Yeah, about the inguinal hernia percentage. So the percentage of incidence is 80%, as mentioned in the Bailey and Love, page 949.
Others?
Others is not stated here, Doctor.
You need to have the percentage to support that there's as a evidence of whatever you are saying. Contohnya?
Okay. Okay. So the next type of the hernia is the umbilical hernia. Okay, so it is common in infant. It is present in infant through weakened umbilical scar. And if adult, they are more susceptible to para-umbilical hernia, which present at weakened linea alba just above the umbilicus. Okay, so for adult, it is more common to have para-umbilical hernia. Okay, so for incisional hernia, it is a hernia through an acquired scar in the abdominal wall. It is caused by the previous surgical operation or injury. For example, the appendectomy scar. Okay, and for femoral hernia, it is a protrusion of extraperitoneal peritoneal sac, and sometimes abdominal content through the femoral canal. Okay, it appears through the femoral canal below and lateral to the pubic tubercle. So here we can see the difference between the femoral hernia and inguinal hernia. You can see inguinal hernia, it is above and medial to pubic tubercle, but for femoral hernia, it is below and lateral to pubic tubercle. Okay, so for epigastric hernia, it present at the epigastric region. It is a protrusion of extraperitoneal fat.
Is epigastric hernia common?
I think because this is the following orders. All of this is common.
I'm asking you, is it common? That's why I'm
Yes.
asking you the percentage.
Ah,
Because I hardly see any epigastric hernia.
I can't tell you the exact percentage, doctor, because I really don't read about the details of the percentage of the types of hernia.
When you're discussing about any disease, you must know, you must cover the incidence.
Sorry, doctor. Do you uh, yeah.
Hmm.
Do you want the value of the percentage now? Can anyone
That is what I've been asking you since tadi lagi. That is what I've been asking you just now. Tadi lagi, banyak kali dah saya tanya.
Doktor, saya Mr.
Ha.
Hakim. Based on NCBI, percentage of inguinal hernia is 70 to 75%.
Based on what?
NCBI, National sekejap. Royal Society of Medicine Press.
That one mana punya tu?
Google,
That one from which country?
Amerika.
Amerika sama ke insiden kat sini?
Sebab buku teks dari Amerika, so mungkin sama.
Apa dia?
Sebab buku teks kan selalu
Excuse me, Bennett, that one is not American, okay? That one is UK. Not all textbook is from America. Some of the textbook is UK, especially surgery. And don't assume everything from America is right. Berapa percentage application hernia? Berapa percentage je? Cepatlah, your time is limited.
I'm sorry, doctor. I cannot answer that. I really don't know. And
Tapi
where to
somebody
search for
was trying to cakap daripada NCBI lah, apa tu, berapa percentage je?
ada form is 1 to 2%.
So is that common 1 to 2%? How come you say that it's a common hernia when the incidence is only 1 or 2%? That's why I'm asking you for the percentage. Because I know you okay on saying epigastric hernia is common, hernia common, tapi percentage tak ada. And we hardly seen any case of that for the past few years. That's why you need to know, you need to include the percentage. We don't ask you to memorize. But at least when you're presenting, you put in the percentage so that we can see clearly, betul ke tak this is common or not? Kalau 1 or 2% incident is considered as common, say all the disease is common. So if you say it's common, you must know about epigastric hernia. You must know as much as you know about inguinal hernia. Faham?
Faham, Doktor? Thank you, Doktor.
That's why you need the percentage. So that you can have a better picture. Betul tak benda ni common ke tak? Kau tadi?
Okay, thank you, Doctor. So that is the for the types of inguinal hernia that is common, and epigastric hernia is not really common. I'm sorry. And this is okay. Next slide. Okay, so this is some varieties of hernia, very rare hernia. So I'm not going to explain any details. So we have T-Jalon hernia, Butyrectal hernia, lumbar hernia, and uterine hernia. Okay, next slide. Okay, so this is some varieties of hernia. So
Varieties, mari dapat varieties of hernia ni.
dalam belly, Doktor.
Does belly and love use varieties?
Wait, I'm not sure belly or brows, but I just refer that to. Wait,
And it's
Okay.
not varieties.
So what is this, Doctor?
Kenapa pula tanya? When you are presenting, you are supposed to be do it properly. Jangan buat lebih kurang apa tu hoping for us to correct everything for you.
If I say it's classification, Doctor?
Belly and love cakap apa?
Belly and love, I jumpa varieties. Yes. Wait, Wait.
This is not time untuk you baru nak buka buku check balik your presentation betul ke tak. You should be checking it before you present.
Doctor, if I say that in the Doctrina Perpetua, it said
Itu bukan textbook.
Oh, okay.
You tahu tak dalam buku tu ada benda yang salah pun ada dalam tu.
So it's not a good reference lah.
Belly and love kata apa? I'm sure dia tak guna varieties. Remember, you're coming into clinical years. Use a proper clinical term. Bukannya ayat sembang-sembang dengan kawan, ayat untuk cakap dengan orang kampung semua tu.
Doktor, in belly and love, dia guna types of hernia by complexity.
Yes. Apa dia?
Types of hernia by complexity.
Yes, that is the proper term. Or you can just say type of hernia. Or you can further sub-classify the hernia. Okay, classification or types of hernia, but it's not varieties of hernia.
Okay. So sorry for that. This is also considered as under the types of hernia. So this is type of hernia. Okay. So there are can I proceed, Doctor?
Even your diagram is wrong. How do you classify, how do you divide the hernia?
It is divided these two, reducible and irreducible.
Any other types of hernia? Or any other classification of hernia?
From belly and love, there are 5. Occult, reducible, irreducible, strangulated, and infarcted, Doctor.
That is when you lump sum everything, but it's not properly classified.
Okay, it's just in the summary.
Okay, that is just list out everything. Continue.
Okay. So I'm just gonna tell you this.
What do you mean by incarcerated hernia? What do you mean by obstructed? What do you mean by strangulation? You need to know all those things.
From what I read, the incarcerated hernia, obstructed hernia, and strangulated hernia can be considered as the complication of the irreducible hernia. So
It's not a
this
complication of irreducible hernia. That is a complication of hernia. Kalau yang reducible pun boleh dapat juga complication tu.
Okay. So the
Please change your mindset daripada pre-clinical years into a clinical years. Jangan nak harap spoon feeding daripada lecturer. You have to prepare study betul-betul. You must study thoroughly before you present. Continue.
Okay. So for incarcerated hernia, it is a hernia that it is a hernia which cannot be reduced because the content of the hernia is adhere to the sac of the hernia, and there are no obstruction or compromisation
You
of
baca
the
kat mana ni?
supply.
You baca kat mana ni?
That one actually ada dalam browse, browse.
Kenapa you tak gunakan, kenapa you tak refer to belly and love? What is definition of incarcerated hernia in belly and love? Continue. Nanti tak sempat habis lah.
Okay, sekejap I need to read ke doktor? Still I need to explain?
Berapa slide lagi you all ada ni?
Macam mana?
Berapa masa lagi you all ada?
5 lagi. Okay. Proceed the incarcerated hernia and strangulated hernia. Okay. So actually we have someone that will explain about that. So maybe I just kind of proceed to the next slide. Okay. So we have okay, I will present about the inguinal hernia. Okay. So this is definition directly from Browse. I refer the Browse book. An inguinal hernia is the protrusion of part of the content of the abdomen through the inguinal region of the abdominal wall. Okay, to understand the inguinal hernia, it is necessary for us to understand the anatomy of the inguinal canal. Okay, so actually we have already encountered the inguinal canal during our preclinical years. So this is the information is actually just for revision. Okay, for us to have.
Skip.
Okay. Skip. So I hope everyone know the inguinal canal already. So this one can skip also. This is also inguinal canal. Okay. So talking about inguinal hernia, there are two types, which is direct inguinal hernia and indirect inguinal hernia. Okay. So for indirect inguinal hernia, okay, everyone need to understand the anatomy of the inguinal canal. So I'm just gonna read this. The indirect inguinal hernia means the hernia sac, it entered the deep inguinal ring. Okay, so I hope everyone know the deep inguinal ring, and it is lateral to the inferior epigastric vessels. Okay, and it transverse the canal. Okay, and it exit through the superficial inguinal ring, and it enter the scrotum. Okay, so I'm just gonna read it.
You are not supposed to be reading it. When you are presenting, you are supposed to present. Bukannya baca, copy paste, lepas tu you baru nak baca masa present. That's why your presentation bila tanya you tak tahu. Continue.
Okay, so for direct inguinal hernia, it is a hernia sac protrude to a weak area in the posterior wall of the inguinal canal, okay, which is known as the Hasselbalch triangle. So I hope everyone can remember what is Hasselbalch triangle. Okay, it is medial to the epigastric vessel. Okay? It passes middle part of the inguinal canal, middle part, and it exits to superficial inguinal ring. Okay, but it does not enter the scrotum, so you can actually differentiate between that two. Okay, I make it as a comparison already. Okay, for the indirect inguinal hernia, it is lateral to the inferior epigastric vessel. For direct inguinal hernia, it is medial to inferior epigastric vessel. And for indirect inguinal hernia, it enters the scrotum, but for direct, it does not enter the scrotum. Okay, and for indirect inguinal hernia, it is especially common in male due to pattern processes vaginalis. So I think Jasmine has already mentioned, okay, the congenital abnormalities that occurs that causes the indirect inguinal hernia. Okay, so I hope everyone understand the pattern processes vaginalis. Or should I think maybe I can read some information from the textbook about the pattern processes vaginalis so that you can understand the indirect inguinal hernia better. Okay, so
You all slide ada berapa lagi slide ni?
uh,
The
okay.
important, the main part tak masuk pun lagi.
So maybe I'm just
Berapa slide lagi? Berapa slide lagi ada ni?
berapa slide lagi ya? Dalam separuh dekat ada saya.
Separuh slide. Masa you tinggal berapa masa lagi? Kenapa you nak baca daripada buku? Just because you are at home, you boleh letak buku sebelah tu. Doesn't mean that when you're presenting, you boleh baca buku macam tu. You baca, orang lain mungkin tak faham apa you baca. Why don't you put on the slide?
Because Jasmine has already explained about it actually.
So, kenapa nak explain? You tahu masa you limited, kenapa you nak explain 2-3 kali benda yang sama?
Okay. So I'm gonna proceed now. Okay, so for indirect inguinal hernia, it is caused by the pattern processes vaginalis. For direct inguinal hernia, it is due to the weak abdominal wall or muscle. So if there are any increase in the intra-abdominal pressure, so it can lead to direct inguinal hernia. Okay, so and for indirect inguinal hernia, narrow neck can lead to strangulation. Okay, for direct inguinal hernia, usually it will have wider neck, so it is less likely to be strangulated. Next slide. Okay, so this is the sign and symptoms of the inguinal hernia. So if the patient comes to you and they will present it with swelling at the inguinal region, and the swelling can be painless or painful. In general, all types of hernia actually is painless, unless if they develop complication. So it might be painful. Okay, and the patient might complain that the lumps get smaller on lying down, and the swelling can be pushed back into the abdomen, what we call as the reducible hernia. Okay, and if the patient complain of painful swelling, so we might suspect strangulated hernia. If the patient complain of colicky pain, so they might have obstruction, okay, the obstructed hernia. And if the patient have Dutch hernia, so they might have change in bowel habit. Okay, so for differential diagnosis of the inguinal swelling, I put here only 3. Actually, there are a lot more. Okay, so the first one is the
Kenapa you
femoral
letak
swelling.
3 je? You know it's a lot more other differential diagnosis. Kenapa you letak 3 je?
Because I think this 3 is the most easy to understand, and
Just because the others you cannot understand doesn't mean that you don't have to know. You kena take shortcut. What if the examiner ask you for 5 differential diagnosis? You nak cakap apa? Dalam kelas kita belajar 3 je, doktor. Takkan nak jawab macam tu? Continue.
okay. So it's sorry, I just picked 3. It's femoral, hydrocephalic, and undescended testis.
When you're giving causes or differential diagnosis, you cannot put just aku rasa nak letak 2 je lah. Tak 1 je lah. Tak boleh. Kalau ada 100 je kena letak. This is your class. Discussion you nak cover, you kena cover semua. Cikgu kena pick I like, I don't like this one lah. This one susah jawab. Tak payah baca lah.
Okay.
Continue.
Okay. So so this is actually just on how we want to differentiate between the differential diagnosis. If the patient comes with the inguinal swelling, then it is reducible. So we need to check whether the swelling is above the inguinal ligament or below the inguinal ligament.
You are-
If it is above the inguinal ligament.
You are discussing about history taking ke you discussing about examination?
History taking.
So apa so you masuk examination?
No, actually I just want, okay.
This is what happen kalau you have too many presenters and then you think your slide is too sikit sangat, you start to masuk benda-benda yang not relevant. Because you have to make it your slide banyak. This examination, you have another class untuk examination kan? Examination lah, habiskan history dulu. History pun tak betul lagi. Continue.
Okay. I think that's all from me, Doctor. Because bawah ni macam banyak pasal examination juga. Okay. So I think I have done with my part, the inguinal hernia. Okay. So we will proceed with the next types of hernia by the other presenter.
Tak tahu ni apa lagi?
Thank you, Doctor.
Kan saya cakap umbilical, inguinal dengan incisional je. Yang lain you baca sendiri. Apa lagi topik yang you all cover?
Anis can proceed. Okay.
Doctor, the rest only just another 3 hernia. But it's just
Continue quickly.
Okay, for the next, this is not common hernia. Umbilical hernia is any hernia that is located at the umbilicus part. It can be congenital or acquired. You can see at this diagram. This one is for PITS patient. You can see the first diagram. There is a scar in linea alba tethered to the skin. And for the second one, congenital umbilical hernia, the umbilical scar fails to form. There is no white sheath. You can see there is no scar because, as you can see in the next picture, the abdominal contents bulge through the weak spot and evade the umbilicus. Okay, on the second part, acquired through umbilical hernia, the umbilicus scar is stretched by a raised intra-abdominal pressure and the umbilicus everts. As you can see, the scar is already formed but it's stretched over the bulging. The next one is para-umbilical hernia. The hernia orifice is at the side of the umbilical scar so that the side bulges out on the umbilicus, you can see, and it will form a crescent shape at the side of the bulging. Okay, next. Okay, for umbilical hernia, this one in children, it occurs up to 10% in infant, higher in premature babies. It will occur few weeks of birth. Sexes are equally affected, but then incidence higher in black infant, commonly in African, not in other countries. For the clinical features, oftenly symptomless, but when increased, it will increase in size when baby crying and assume a classic conical shape. It's like you can see in the diagram is a conical shape protruding out from the umbilical. Okay, next. Okay, this one no need. Okay, next. Okay, for adults, it will cause, usually for adult is acquired, not congenital. Condition that cause stretching and thinning of the midline, which is linea alba. For example, because of due to pregnancy, obesity, and liver disease with cirrhosis. Okay, this one already mentioned for the true umbilical in the diagram previously. But for umbilical hernia in adult, commonly the term used is para-umbilical hernia. It's common acquired umbilical hernia in adults. If there is small umbilical hernias, often contain extraperitoneal fat or omentum. If it's larger hernia, it can contain small or large bowel. But even when very large, the neck of the side is narrow compared with the volume of its content. You can see in the diagram, I put it there. If this one is a large hernia, it will have a small or large bowel. Okay, for the clinical features, the patient might have swelling and discomfort, pain and tenderness around the umbilicus. It will be worsened if the patient is standing or doing strenuous exercise. Okay, okay, the patch is beside to one side. I already mentioned just now. You can see clearly it's crescent shape. Okay, in the large hernias, the overlying skin may become thin, stretch, and develop dermatitis because of the content is too heavy. The volume. I mean, the volume is more than the neck. Sorry. Okay, next. This one is a happy gastric hernia, which is less common, only 1 to 2% considered as a rarer type of hernia. Okay, I won't touch about the definition already mentioned previously. Okay, for this hernia, it arises through the midline at the linea alba, anywhere between the xiphoid to the umbilicus. You can see in the picture very clearly at the xiphisternum and it's at the medially at the linea alba and be up superior to the umbilicus. That's why in epigastric region. Okay, when it close to umbilicus, it will called as a supraumbilical hernia. Like mentioned just now, for umbilical, it will round and it will round. But for epigastric, usually the defect is elliptical. It's more oval. You can see in the picture below, it has been hypothesized that the defect usually occurs at the site where small blood vessels pierce the linea alba, or more likely that it arises at venous due to abnormal decussation of lymphatic fibers. Usually, due to heavy physical activity, like those who love to weight heavy lifting. It will look as just like as the pictures. Epigastric hernia defect usually less than 1 centimeter in maximum diameter, commonly contain only extraperitoneal fat which can enlarge, spreading in the subcutaneous plane to resemble the shape of a mushroom. When it becomes very, very large, a peritoneal sac, but rarely any bowel. More than one hernia may be present, but usually this one is very less common type of hernia. Okay, next. Okay, for the clinical features, that's why just now I mentioned usually those who love weight heavy lifting. That's why usually patients are often fit, healthy men aged between 25 to 40 years. It can be very painful, even when the swelling is the size of even it's small, but thing can be very painful. And sometimes this one is associated with when a patient is eating and sitting on the chair, it will usually patient will describe as peptic ulcer because the pain may mimic peptic ulcer. Its soft midline swelling can be felt more easily than seen. It may be locally tender. It is unlikely to be visible because of the narrow neck. You can see narrow neck. It may resemble a lipoma. This one, cuff impulse may not be found in under examination. Okay, next. Okay, next for incisional hernia. This one will arise through a defect in musculofacial layers of the abdominal wall in the region of post-operative scar. You need to understand that incision hernia happen after doing a surgery, post-operative surgery. Then the hernia will develop. It can appear anywhere on the abdominal surface because it's not region type of hernia. It's because of the surgery. Usually, it starts as destruction of the musculofacial layers of a wound in the early post-operative period. Often, the event passes unnoticed if the overlying skin wound have healed securely, meaning that if the surgery scar already healed securely, so sometimes it may not be noticed, the hernia. But this type of hernia can be preventable if use of good surgical technique. Okay, kasi sang surgery is a sero-incisional discharge ni because of the wound tadi tu.
What do you say just now about incision hernia?
Due to
What is the pathogenesis?
because of the I think I couldn't find pathogenesis in the belly, but then I think it's because of the incidence and etiology I'm going to discuss later.
Because of what? You cannot answer macam tu. Kalau tanya, you have to answer the question. Bukan, I'm going to answer later. It's in my next slides.
Doctor, for the pathogenesis, what I understand because of the surgery, and also because of the patient factors, wound factors, and surgical factors.
What is the pathogenesis? Just patient having surgery, this is not that's not pathogenesis.
Sorry, because I couldn't find in uh, doctor, is it because of the patient factors, for example, like general, I think the pathogenesis, the causes is because of due to many causes, so it will the causes vary.
Continue.
Okay, why this incidental hernia can happen has been reported in 10 to 50% of laparotomy incisions and 10 to 5% of laparoscopic incision. Okay, from here, we can see why that laparotomy is higher than laparoscopy, because laparotomy is a, do you guys understand what is laparotomy and laparoscopy? Okay, never mind. Laparoscopy is using a multiple small incision. It's a newer technique. So it will not causing a large incision. But laparotomy, it need a large incision. That's why more opening of the abdomen.
Are you sure there's more opening in the abdomen in laparotomy than laparoscopy?
Because yeah, what I understand is laparotomy is using a single large incision. But
So
laparoscopy,
there's only one incision. There's only one incision. Kenapa pula laparotomy ada multiple incision?
no, I mean laparoscopy. Doctor just now explained about laparoscopy is multiple small incisions. But laparotomy is one large incision.
So that's all laparoscopic scar can develop into hernia.
Pardon, doctor?
That's all laparoscopic scar has a risk to develop into hernia.
Because what I understand, because laparotomy is more, it's cause more opening. That's why it can reported.
I'm asking you, that's all the laparoscopic scar has the risk to develop hernia.
Yes, because it reported that it has caused incident.
Have you seen a laparoscopic surgery?
No, doctor, just a video.
Not all insertion site, not all port site will develop hernia. It's only certain size the risk of can have a risk to develop hernia. Otherwise, it's smaller than that. There's no risk.
Okay.
Continue.
Okay, thank you, doctor. And the next one, inspection factors due to patient is obese, general poor healing due to malnutrition of nutrition, immunosuppression, the patient took steroid therapy, chronic cough, maybe the patient have cancer. And it may be because of wound factors, poor quality tissues, and wound infection. And for surgical factors, inappropriate suture material or incorrect suture placement. Okay, next. For the clinical features, it may have localized swelling involving a small portion of scar but may present as a diffuse bulging of the whole. You can see in the first picture, the first diagram, it will have diffuse bulging of the whole length of the incision. It's diffuse, it's not just one hernia. And then,
So that's all incisional hernia have to have that kind of bulging.
pardon, doctor, sorry.
Is it typical for all incisional hernia to involve the whole length of the scar?
Not necessarily, depends on the patient.
Which scar yang cause the hernia?
Surgical scar.
I know lah surgical scar, mana ada scar lain selain daripada surgical scar? Which part of the scar yang cause the hernia?
Scar yang
Which layer of the abdomen that cause the hernia?
musculofacial layers.
Huh?
Musculofacial layers of the abdomen.
Which part of the abdomen?
Uh,
When talking about laparotomy scar, midline laparotomy, which layer of the abdomen yang can cause the hernia?
umbilical.
Umbilical?
Sorry.
You talking about insertional hernia?
Muscle layer, doctor.
Which layer?
Muscle layer and fascial
Which layer? What muscle? You say muscle layer, what muscle?
external oblique.
Midline laparotomy. What is the external oblique? Where is the incision and origin of the external oblique? Where is the muscle located?
Uh,
Rectus abdominis.
Huh?
Rectus abdominis muscle.
rectus abdominis layer, doctor.
Rectus abdominis?
Yes.
Okay, now tell me about anatomy of the anterior abdominal wall. Bila you masuk incisional hernia, anatomy abdominal wall tak masuk pula. Tell me layers of the anatomy of the anterior abdominal wall.
It has 3 layer, which is like lateral oblique muscle, external oblique, internal oblique, and the oblique appendix. The other one is external and internal.
Okay, if from skin, start from the skin. Tell me the layer of the anterior abdominal wall.
Anterior abdominal wall have a few layers. First skin. After skin is a superficial fascia, which is include camper fascia and scapa fascia. Lepas tu it have after scapa fascia is external oblique muscles, and then external oblique fascia. After that internal oblique muscles, internal oblique fascia, and then transverse.
You're missing out the anatomy.
Huh?
What does extra in the abdominal layer? Anterior abdominal wall. Kalau you tengok dalam mall pun ada, dalam snail pun ada gambar.
Maksud doktor Marcus ke apa?
Doctor, can I try? From the outer layer to inner layer, it has skin, started with skin, superficial fascia, muscles, the 3 muscles, external oblique, internal oblique, transversus abdominis, rectus abdominis,
Wrong. Apa yang ada dekat anterior abdominal wall?
extraperitoneal fat.
That one kat dalam. Apa lagi ada kat anterior abdominal wall? What is the strongest layer of the abdominal wall?
Superficial fascia.
No? Superficial fascia?
Peritoneum.
Peritoneum is the strongest layer. Peritoneum is a very thin layer. You koyak ke tangan pun putus.
Doctor, is it linear alba? Because it's midline.
No? What is the strongest layer of the abdominal wall?
Rectus sheath.
Rectus sheath.
So where in your anatomy, kenapa in your anatomy tak ada rectus sheath?
Sorry, Doctor, my bad. I forgot about rectus sheath just now.
Sebab you all baca lecture note je, you all tak baca buku. You need to read the textbook. Anatomy textbook as well. Whatever in your lecture note masa first year and second year is not enough. They cannot cover everything. You have to go back and read daripada textbook. The detailed explanation, all those other things sekali. Continue.
Thank you, doctor. Okay, for it tend to increase steadily in size with time. Skin overlying large hernia may become thin and atrophic, so that when it becomes too thin, peristalsis may be seen in the underlying intestine. And also, if there is a vascular damage to skin, it can lead to dermatitis of the abdomen skin. Strangulation is less frequent in this hernia and it's most likely to occur if the fat is small and the sac is large. Because of this, it have broad neck of the hernia. It carry a low risk of strangulation. Okay, next. Okay, next one is femoral hernia. Incidence it's reported that due to anatomy of female pelvis has a different shape to the male, so that's why it increases the size of the femoral canal and the risk of the having hernia in female. And in old age, the femoral defect increases, and femoral hernia is commonly seen in low-weight elderly women. And also, there's a report by Denmark Hernia Registry. There's also substantial risk of developing a femoral hernia after a sutured inguinal hernia repair. I'm not really sure how extent due to this sutured inguinal hernia repair can cause this femoral hernia. For the clinical features, it will appear below and lateral to the pubic to the tubercle, and it lies in the upper leg rather than in the lower abdomen. It will cause swelling. Partial strangulation of the bowel wall is likely because of it has narrow neck. It also reported that femoral hernias are occasionally bilateral, but then in this diagram only unilateral. It may only 1 to 2 cm in size, so that's why because of its small size, it can be mistaken as lymph node or swelling. And when it increases in size, it will reflect it superiorly and becomes difficult to distinguish from a medial direct hernia because the location is near. And then direct inguinal hernia will leave the abdominal cavity just above the inguinal ligament, and femoral hernia just below it. As you can see in this diagram, this patient have a left femoral hernia on his left leg and the right inguinal hernia. So it may hardly to be distinguished because of the location is quite nearer. And then for the differential diagnosis, because when it can, because of the location, it may mistakenly diagnosed as direct inguinal hernia, and because of the size, can be mistakenly diagnosed as lymph node swelling. Do you guys, any of you remember what kind of lymph node in the femoral canal? Anyone want to try?
Gland of clock Avenda CLOQUET.
Okay, thank you so much, Ainul. Yes, it's correct. I don't know how to pronounce cloque or cloquet. Lymph node tu lah. Near is in the content of the femoral canal.
What do you mean by the name of the type of notes?
I think
What's the question just now?
I asked what the name of the
What kind of you are asking Jenna what kind of notes?
bukan what name of the node in the femoral canal.
That is not important.
Okay, sorry, doctor.
And why don't you put in your slide?
I didn't put, I just the differential diagnosis.
Continue.
Okay, and next one is it can be mistakenly diagnosed as saphenous varix. Saphenous varix is dilation of the saphenous vein. Okay, you can see in the picture because of the location, it can be mistakenly diagnosed. And there's femoral artery aneurysm. Source abscess is the muscle of the soft infection, there's infection. And then next one, is rupture of adductor longus with hematoma. Sos bursa also can be misdiagnosed. And
Apa dia?
sos bursa.
SOAS.
Sorry, Dr. Sowas bursa. Okay, for the next two last point is I took it from brows, and the rest is from belly. And last one is the lipoma.
Huh?
Okay. The last one is lipoma can be mistakenly diagnosed.
Lipoma.
Okay, doctor, lipoma. Thank you, doctor. Okay, next. Okay, for the sign and symptom, this one is just
And tadi kan dah present dah sign symptom kan?
yes, doctor. I just mentioned this is just summary. I would explain. Okay, that's all from me. Thank you, doctor.
Good afternoon, Doctor. My name is Michalini, and I'll now continue the presentation on history taking.
History taking tadi kan dah mention. Dah masuk kan presentation risk factor semua kan dah masuk.
Next slide, please. It's about the flow on how to take history, Doctor. But basically,
That's covered tadi kan?
Yes.
You nak gain consent apa benda patient you nak get history? Continue.
I'll just proceed straight to the complications then, Doctor. Okay.
This one pun tadi dah masuk cerita kenapa Pak? This what happen when you have too many presenters. Semua buat cakap, lepas tu cakap sana cerita sikit, kepala kat sana isi kat tempat lain. This is what happen. Berapa slide lagi ada ni?
That's all, Doctor. Last
Huh? I cannot hear you. You very soft.
The complication is the
Cakap
last
kuat
part.
sikit. Huh?
The complication is the last part. Dah habis dah.
Go back to the previous slide. Continue.
Should I present this slide, Doctor?
Continue.
Okay. For the complications of hernia, in most cases, the herniated contents can be manipulated back into the abdominal cavity. So that is what is called as reducible hernia. But in some cases, there can be complications. Like mentioned just now, it can be incarcerated hernia, obstructed or strangulated hernia. Incarcerated hernia means when tissue is trapped inside the hernia, it is in a confined space. So the adhesions formed between the content or bowel and the hernia sac makes it to become imprisoned in the sac of hernia. So in incarcerated hernia, the contents are usually fixed in the sac, but the hernia is irreducible, but the bowel is not strangulated or obstructed. As for obstructed hernia, when the part of gut herniates, the bowel contents may no longer to be able to pass through the herniated area. Which is why in some patients there are intestinal obstruction sign and symptoms such as vomiting, colicky abdominal pain, and constipation. In this form of hernia, the lumen is the part that is obstructed, but the vascular supply remains intact. As for strangulated hernia, the compression or twisting will increase the pressure within the hernia. So when the pressure rises sufficiently, the arterial blood is not able to enter the hernia, and that part of the content becomes ischemic and may infect, which is why which is why the symptom pain is seen in some patients. That's all. Thank you.
Okay, habis dah?
Dah.
Okay, any question? Any question? Yang lain clear tak?
InsyaAllah.
I have a question. But is it okay if I ask the one that?
Ask the presenter first.
Okay, sorry, doctor. I'm the presenter. Just because I tried to find in the, but I cannot find the answer to my question. Can I
Question apa?
for the umbilical hernia? Because in the belly it mentioned that incidence in black infant is higher than white infant. Because of what?
Because of what? It doesn't matter. You have to go back and read what is the pathogenesis. Sometimes there's no the incident just takkan tanya kenapa benda ni more in Chinese or more in male or more in female, more in Indian, more in Malay.
Okay.
And what are you talking about? Dia talking blacks and white is not relevant. It's not. Kat sini ada ke black and white?
Oh no doctor.
Tak ada.
Oh, I just wonder, is it because of the nutrition or something? No, okay, got it. Doctor, thank you.
What is the pathogenesis? How does develop the umbilical hernia?
It's because of the umbilical cords fail to obliterated.
Why does it fail to obliterate it?
Wait, doctor. From it's just because of the abnormality of the baby. Because maybe because of the incomplete closure of the fascia of the umbilical ring.
Yalah, that's why it become hernia because there's no the fascia does not close. But why does not close? Is there any explanation why does not close?
I'm not sure that is it because of the
Sometimes all those trivial thing tak perlu you nak go dig dalam-dalam sangat.
okay.
Okay, and sometimes there's no explanation.
Alright.
That is just based on study.
Okay, thank you, doctor.
You have to see itu yang study tahun bila? Buat kat mana? Okay, it might be related to nutrition, might not be related to nutrition at all. It might be related to genetic, we don't know. But there's no explanation to explain why it is more common in black rather than in white.
Okay. Thank you, doctor.
Okay, any other question? Tak ada soalan dah? Mana ketua kumpulan? Attendance semua datang? Ha? Ada apa? Saya tanya dah semua ada ke?
Semua ada, doktor.
Ha. Siapa yang ambil attendance?
We will send the attendance list to you later, doctor.
Tak, you ni, you ketua kumpulan kan? You have to be alert. Yang attendance semua datang ke? Ada yang tak attend ke apa? Lepas habis lecture, kenapa tak capture masa ambil lecture tu? What if dia datang 5 minit sebelum habis kelas? Sebab di academic they might ask you for your classmate attendance juga nanti. You have to take note lah. You can check kan berapa orang participant. You can at least check roughly tahu ada cukup ke tak. Okay, ada soalan tak? Okay, if there's no question then we end the class lah. You go back, baca balik. What is the pathogenesis of the hernia? How does it develop? All those things. Okay? Okay, thank you.
Okay,
Thank you, doctor.
Okay, doktor.
Thank you, Doctor.